Hello and welcome to Cardiology 101. This is Dr. Shiraz and today we are going to talk about our left bundle branch block. Before I talk about what is left bundle branch block, I'm going to talk about why is it so important to discuss about this. In many heart pathologies, this is a very common conductional block and it also worsens the prognosis of the heart pathology. Sometimes it comes with acute myocardial infarction, for example, anterior wall MI. So with new onset left bundle branch block, it is usually coming with anterior wall MI. So it is important to learn about left bundle branch block. And because it changes the conduction of left ventricle, it also affects on the ejection fraction. So sometimes with left bundle branch block, we see decreased ejection fraction. All right. So if you look at this, our current generates from here. This is our SA node and then goes to the AV node, and AV node then goes to, this is our bundle of His. All right. This is our bundle of His. This then divides into left bundle branch and right bundle branch. All right. Then they again go to the ventricles and they give Purkinje fibers. They also have other branches too, but we will talk about it later. So for example, if there is a bundle branch block here, right here, we will see that the conduction below this part will be impaired, and since the conduction is impaired, so will be the contraction of the myocardium below that part. So overall, our left bundle branch block not only changes the electrical activity of the heart, but also the contractility and overall functioning of the myocardium. What are the ECG findings in left bundle branch block? I want to tell you here that for left bundle branch block or right bundle branch block, the leads that you should be looking for are the precordial leads that are V1 to V6. You can also look for axis and you can also look for lead 1 and lead AVL. I will talk about it in detail later. Alright. The next clue, the first clue we will have is our broad QRS complexes in V1 to V6. We discussed what is broad QRS complex. Any QRS complex which has width of more than 120 milliseconds or almost 3 small blocks. So if it is wider than 3 small blocks, we will call it broad QRS complex. Slurring of S wave in V1. Usually in V1 we see a very small bump of R wave and then a S wave. But in left bundle branch block we will see a deep S wave with slurring or notching. Alright, similarly slurring of R wave in V6 or left-sided precordial leads. What are left-sided precordial leads? V5, V6, and if we go a little higher, then there is high lateral area of the heart which is represented by lead 1 and lead AVL. So we can see slurring of R wave in V6, lead 1 and lead AVL. Another point is discordant STT changes. So what do I mean by discordant STT changes? So for example, I said the slurring of S wave in V1. So S wave is negatively deflected from isoelectric line, right? So if in V1 I have negative QRS complex, my ST segment would be elevated. QRS complex is negatively deflected, but ST segment is elevated. We have ST segment elevation. Alright, similarly our T wave would be positive. So, and in the case of V6, what we see is our R wave. So our QRS complex is positively deflected, but our ST segment and T wave would be negatively deflected. Our ST segment would have depression and our T wave will have inversion. Alright, this is our discordant STT changes. I hope this cleared your concept. So let's look at the examples of left bundle branch block. So this is a mnemonic to remember left bundle branch block, and it is called Willem because if you look at this word, it has two L in between. All right, this is our left bundle branch block. So in V1 we will have a W pattern. You can see that this is negatively deflected waves and this shows our slurring. This point shows our slurring, and in V6 we will have a positively deflected QRS complexes but with slurring. Alright, so if you look at V1 and if I draw it here, it's look like this. Alright, a W pattern, right? And if I draw this QRS complex, this is almost like M. So if you see this pattern in V1 and V6, then this is our left bundle branch block. And other clues here are that our QRS complexes are broader than 3 small blocks, right? And disconcordant STT changes. So for example, if you look at here, this ST segment is elevated, right? And our T wave is positive, but our QRS complex is negative. So disconcordant STT changes. And similarly, in V6, we have positive QRS complex, but our depressed ST segment and T wave invariant. This is our T wave invariant, all right? So I hope this cleared your concept. If I look at V1, for example, it is S wave which is slurred and our ST segment is elevated with positive T wave and our QRS complex is broader than 3 small blocks. Similarly, in V6, I have R complex or positive QRS complex, but our ST segment is depressed and our T wave is inverted and there is small slurring here. So this is our left bundle branch block. Another point I would like you to know is sometimes we do not see a complete block. So what happens in incomplete block, our QRS complex is 100 to 120 millisecond wider. So it would be almost 2.5 to 3 small blocks wider, and we will call it incomplete left bundle branch block. All right. Another point before I forget is in left bundle branch block, our axis can be left axis deviation, right axis deviation, or normal axis. In this picture, one is pointing upward and lead AVF is pointing upward. So this is our normal axis. All right. So if I start looking at V1, I will see a S wave. Our QRS complexes are from the start of R wave to the end of S wave is almost 3 small blocks or more than 3 small blocks. So we have our broad QRS complexes, our ST segment is elevated and T wave is positive. But in the case of V6, we see a slurred R wave making a M pattern. All right, we discussed in Willem that M pattern in V6 is that of left bundle branch block, and our ST segment is depressed and our T wave is inverted. I also told you that our slurred R wave is also seen in left precordial leads in high lateral leads, for example 1 and AVL. So if you look at 1, similarly you will see that R wave is slurred, and in AVL R wave is slurred. So this is our left bundle branch block. All right. Another example here. What is the axis here? It is pointing upwards, it is pointing downwards. So this is our left axis deviation. All right. And this is our more than 3 small blocks wider QRS complex. So it is a broad QRS complex. We will see small notching of S wave here if you look closely. And again, our ST segment is slightly elevated with positive T wave, but in V6 we cannot actually see the left bundle branch block trademark pattern, but ST segment is depressed and T wave is inverted as R wave is slightly slurred. If you see that here is a little slur, and similarly in 1 and AVL we see that R wave is slurred. So this is our left bundle branch block. I hope this cleared your concept. If you have any question, you should ask me in the comments and I will be happy to respond to them. Next up, we will have our right bundle branch block and a very important concept, that is STEMI in the presence of left bundle branch block. Because I said sometimes new onset left bundle branch block is STEMI mimic, because it is STEMI actually, it is anterior wall MI. We will talk about how to identify STEMI in the presence of a left bundle branch block through Sgarbosa criteria and Smith modified Sgarbosa criteria. So I will see you in the next video. Thank you so much for signing in today.